To give or not to give? That will be answered. Following this slide will be a brief summary on an article called Resolving Variable Maternal D-Typing Using Serology and Genotyping in Selected Prenatal Patients. You can also click on the link below to read the full article. We all know that preventing alloimmunization of Rh-negative women from their D-positive fetuses are by administering RhoGAM at 28 weeks and then again shortly after delivery. This article brings up the concern that women are unnecessarily receiving RhoGAM, as well as actually people receiving Rh-negative blood when they can actually get Rh-positive blood. The reason why we are becoming more concerned with this process is because various labs are using various methods, as well as multiple anti-D reagents are being used. Discrepancies among these differences have created a concern that the actual RhD type may not be accurate. The College of American Pathologists of Transfusion Medicine Resource Committee recommends that Rh genotyping be performed on select patients. There are also additional recommendations by other groups as to when you're supposed to perform the genotyping. Because of these concerns, the Canadian Blood Centre has performed a study using standardized processes and algorithms. They identified true D-negative prenatal women from weak D and D-positive women. The study was conducted from 2011 to 2004. Now, for them to start the process deciding on who actually needs the genotyping performed, what they've decided to do is follow this algorithm that you can see here. It starts out with your typical testing, which is usually performed on the solid phase platform using Series 4 and Series 5 anti-D monoclonal reagents. So here you can see here that whenever you have both 4 and 5 greater than or equal to 1+, you're just going to call them a positive. Here, if you go this route, you can see that both Series 4 and Series 5 are negative, and of course, we're going to call them negative. The problem is when we get this here discrepancy that is happening, where you might get Series 4 where it's a 1+ and Series 5 a negative, or you might get a no type determined. You get these question marks. You might get a 1+ or a 3+. Again, you're going to have varying variable results, and so you're kind of concerned on what you should actually call this patient. So what they've decided is to go ahead and perform tube testing using direct agglutination and tube method with a 5-minute room temp incubation, using Series 4, Series 5, as well as this NovaClone reagent. They're using 3 reagents. And the reason behind this is so that way they're not, again, spending money they don't need to on genotyping tests when they can actually feel pretty confident ruling out Rh positive, or ruling in or out Rh positive, Rh negative patients. So you can go, once you do this and you go down here and you get 2 out of the 3 reagents that are positive with a 2+ or greater, then you can consider them Rh positive. If you go this route and you get negative results, then you're going to call them negative. Again, if you're getting this here, then you know that you need to perform genotype testing. And usually this is because there's variable results. You've got one maybe a 1+ or negative, another one with a 2 or 3+. Again, this is considered discrepant results. Or if you have a patient who, say you were doing tube tests before, you might have the patient categorized as Rh positive. Now you're using a different method, and now you're thinking they're Rh negative. This is going to help rule it out whether or not you need to either call them Rh positive, Rh negative, or if you need to do genotyping. And this slide here is just providing a summary of the algorithm on the previous slide, just saying that Series 4, 5, and NovaClone anti-D reagents are used to help identify D positive from D negative patients without spending unnecessary money on genotyping. If discordant results are presented, then genotyping is performed. So when genotyping needed to be done, the testing performed was the blood chip or the bead chip assay. Again, the Canadian Blood Center tried to keep this as standardized as possible to provide the best possible results. Anytime no defined genetic variant was identified with this testing, then they would switch over to the Sanger sequencing. They had to do this in 32 cases. This study actually covered over 608,000 prenatal women, and they identified weak D, partial D, mutations, variants, though the most common was the weak D and partial D. And with these 608,000 patients, 79,000 of them were D negative. The serology variable was 351, so 21 of those, there were no variants detected. 17 were confirmed actually Rh positive, and that with sequencing testing. 4 of them were Rh negative, and our variant D was 330. So 213 were actually weak D. 117 were other variations. So you had 17 with mutations, again confirmed by the sequencing. 22 compound heterozygosity for 2 RHD alleles, and then 67 RHD variants and 11 unresolved variants. In summary, they identified D negative from D positive in prenatal women. 60% of these women avoided RhoGAM administration, and 13% were actually considered D negative. Testing will vary, obviously, based on population being tested in your area and the number of and type of D reagents that are being used. Using the 3 reagents will actually help to minimize the cost and reduce further testing if it's not necessary. There are some cons along with this. Those would be the partial Ds may react as Rh positive if you follow the algorithm. What's happening is there's a mutation that they found in a few of the patients where you have this RHD DAU0 mutation. It's carries the DAU5 allele, and what happened is these women were all immunized during pregnancy. The pros is, of course, standardized algorithms, cost. It also limits unnecessary testing, and then, of course, prevents administration of RhoGAM or Rh negative blood, so that's not being wasted with our limited resources. Thank you for watching, and please post with any questions.